Let's start by defining what chronic obstructive pulmonary disease means. Chronic means that it lasts for a long time. Obstructive tells us airflow into the lungs is obstructed. Pulmonary, related to the lungs. And disease, abnormal condition negatively affecting health. Chronic obstructive pulmonary disease is a progressive disease characterized by airflow limitation and obstruction that is irreversible. COPD is a condition that is made up of both emphysema and chronic bronchitis. The airflow limitation is associated with abnormal inflammatory responses of the lungs, primarily caused by smoking cigarettes. Let's take a closer look at emphysema and chronic bronchitis. Emphysema is a disease affecting alveoli in the lungs. Noxious particles from cigarette smoking trigger inflammation, and a protein called elastin in the alveoli gets destroyed. Elastin is important as it is responsible for the recoil in the alveoli, which expels out the air when we breathe out. Elastin can also be destroyed by a condition called alpha-1 antitrypsin deficiency. If it is destroyed, air is trapped in the alveoli, and this is the reason that exhalation in COPD is difficult. The alveoli are prone to collapsing due to the positive pressure upon expiration. They can also dilate, which can eventually lead to the formation of lung bullae. These patients can be referred to as pink puffers, as they are breathless but they're not cyanosed. On the other hand, chronic bronchitis is a disease that affects the airways in the lungs. It is characterized by a productive cough occurring for over 3 months a year for 2 years. In chronic bronchitis, there is hypertrophy and hyperplasia of goblet cells and mucus glands, leading to higher mucus production and more frequent lung infections. This causes a narrowing of the airways, leaving patients cyanosed as not enough oxygen is able to go to the lungs. These patients are referred to as blue bloaters, as they are cyanosed but not breathless. A condition called cor pulmonale can be a complication of COPD. Cor pulmonale is defined as heart failure due to pulmonary causes. This happens because hypoxia induces vasoconstriction of the pulmonary blood vessels. This results in pressure in these vessels increasing, so the right side of the heart must work harder to overcome it, which leads to right-sided heart failure, or cor pulmonale. The biggest risk factor for developing chronic obstructive pulmonary disease is cigarette smoking. Other risk factors are advanced age, environmental and occupational hazards such as air pollution or chemicals, and genetic factors like alpha-1 antitrypsin deficiency. The most common symptoms are a productive cough, shortness of breath with exercises, which progresses to shortness of breath at rest. This is best evaluated by exercise tolerance tests, and the Medical Research Council, or MRC, has certain grades of breathlessness ranging from 1 to 5 that gradually worsen as you go up the grade. The signs of COPD are a barrel chest, hyperinflation of the lungs, which can be seen on the X-ray, the use of accessory muscles for breathing, and pursed lip breathing. Percussion of the chest may reveal a hyperresonant sound. And on auscultation, you may hear bilateral wheeze and crackles. The principal investigation for COPD is spirometry. This is used to assess the level of obstruction in the airways. It measures forced vital capacity, which is the largest amount of air a person can exhale during a full breath. It also measures forced expiratory volume over 1 second, or FEV1. This shows us how much of the forced vital capacity can be expelled from the lungs within 1 second. Spirometry results can be visualized on a graph like this. The blue line represents a healthy patient, and the red line represents a patient with obstructive lung disease, such as COPD. We can see that in a healthy patient, around 80% or more of the forced vital capacity is exhaled within 1 second, or the FEV1. In the patient with COPD, we can see that a lower percentage, which is typically below 70% of air, is exhaled in the first second, but the total lung capacity stays the same. The FEV1 to FVC ratio is less than 0.7 in obstructive lung disease, and in healthy patients it is above 0.8. Also, for COPD, patients are given a bronchodilator before spirometry to prove that the airflow obstruction that is seen is non-reversible. Other key investigations are a chest X-ray, which may show lung bullae, hyperinflation, flattened hemidiaphragm, and areas of consolidation in the lungs. A pulse oximetry may show saturations less than 92%, but in COPD, levels of 88 to 92% are acceptable. Arterial blood gas, which is more for acutely unwell patients, may show hypercapnia, hypoxia, and respiratory acidosis, which may all be preceding signs of respiratory failure. We would do a full blood count to check for polycythemia, anemia, and leukocytosis. We would also want to do an electrocardiogram for signs of heart dysfunction such as right ventricular hypertrophy, which may be caused by increased pulmonary pressures. To manage chronic obstructive pulmonary disease, the first step is lifestyle advice. All patients are recommended to stop smoking if they are currently smoking or not to take up smoking. Nicotine replacement therapy, drug therapy, and other non-pharmacological therapies are recommended. Patients also require an annual influenza vaccine and a one-off pneumococcal vaccine. They should be offered pulmonary rehabilitation, which is a kind of chest physiotherapy, where patients can do physical exercises to try and improve lung function and are also educated about managing their COPD. For pharmacological management, guidance recommends using a short-acting beta agonist or a short-acting muscarinic antagonist as needed. If symptoms are persistent throughout the day and the patient has asthmatic features, which is an FEV1 less than 50%, then we can give a long-acting beta agonist and an inhaled corticosteroid. If there is no asthmatic features, we can give a long-acting beta agonist and a long-acting muscarinic antagonist. In both cases, if symptoms are still persistent, we will add the missing medication. For example, for asthmatic features, we will add a long-acting muscarinic antagonist, and for no asthmatic features, we will add an inhaled corticosteroid. Other drugs, such as mucolytics, can be considered if a patient has chronic productive cough with no improvement. Long-term oxygen therapy is a treatment that reduces mortality if it's given for more than 15 hours per day. However, certain conditions must be met, as patients must be clinically stable, non-smokers, with a partial pressure of oxygen less than 7.3. Or patients can have a partial pressure of oxygen less than 8 and any one of pulmonary hypertension, secondary polycythemia, peripheral edema, or nocturnal hypoxia. In summary, we have covered the definitions of COPD, including emphysema and chronic bronchitis, the risk factors, mainly smoking and occupational and environmental hazards, the symptoms and signs, such as a productive cough and breathlessness, the investigations, spirometry, X-ray, blood tests, and ECG, the management, stopping smoking, various inhalers and steroid treatment, and long-term oxygen therapy. Thank you for watching. Be sure to share the video if you found it useful and keep up to date on rekapmed.com.